Welcome back to Master USMLE, where we break down high-yield Step 2 CK topics in a way that makes sense. Today we're talking about cardiac tamponade, a rapidly fatal emergency that you must recognize and manage quickly. Case scenario. You're working the night shift in the ER when a 50-year-old woman arrives after a minor car accident. She was stable initially but now looks pale, diaphoretic, and short of breath. Her blood pressure is 78/40, pulse is 135, and her jugular veins are distended. Heart sounds are distant, but her lungs are clear. This isn't just shock, it's cardiac tamponade from traumatic pericardial bleeding. Pathophysiology and hemodynamic changes. In tamponade, fluid rapidly accumulates in the pericardium, preventing normal cardiac filling. The key to understanding tamponade is that all four chambers experience increased diastolic pressures until they equalize with pericardial pressure. Let's break it down. Right atrial pressure, URAP, increased due to restricted venous return and chamber compression, leads to jugular venous distension, JVD, pulmonary capillary wedge pressure, PCWP, normally reflects left atrial pressure, but increases because the left atrium is compressed. Unlike other shock states, e.g. pulmonary embolism, PCWP remains high despite low cardiac output. Cardiac index, CI down, represents cardiac output per body surface area. Decreases because the heart can't fill properly, reducing stroke volume and cardiac output. Leads to hypotension and obstructive shock. Systemic vascular resistance, SVR, increases reflex vasoconstriction occurs to maintain perfusion in response to low cardiac output. This is why extremities may be cold and clammy. Right ventricular end diastolic pressure, RVEDP. Right ventricle is compressed first because it's a low-pressure chamber. Leads to pulsus paradoxus, a drop in systolic blood pressure greater than 10 millimeters of mercury during inspiration due to further right ventricular filling restriction. How does this show up on USMLE? Classic triad, Beck's triad. Hypotension, low cardiac output. JVD, high right atrial pressure. Muffled heart sounds, fluid-insulated heart. ECG findings, low voltage QRS from pericardial fluid. Electrical alternans, varying QRS amplitude, due to heart swinging in fluid. Pulsus paradoxus. Blood pressure drops greater than 10 millimeters of mercury during inspiration due to further right ventricular restriction. Key differentiator from other shock types. Tamponade equals high PCWP, high RAP, low CI, high SVR. Pulmonary embolism equals high RAP, low PCWP, low CI, high SVR. Septic shock equals low SVR, high CI, low PCWP. Management pericardiocentesis. Immediate drainage to relieve pressure. IV fluids. Temporarily increases preload and maintains right-sided filling. Pericardial window, if recurrent or post-surgical. Key takeaway. If you see sudden hypotension, JVD, and clear lungs, think cardiac tamponade. The key is recognizing high PCWP, high RAP, low CI, and high SVR, a unique shock state that demands urgent intervention. That's it for today. Keep studying, stay sharp, and master the USMLE.